My name is Dr. Wally Kernodle. I'm a rheumatologist at the Kernodle Clinic, and we're going to talk today about bone health and issues in osteoporosis. Osteoporosis is a disease that weakens bones, and weakened bones are more likely to fracture. It can affect men and women, but postmenopausal women are the ones at most risk. This is a picture of a spine. This is a lateral thoracic spine. If you look at that vertebra, you can almost see through it. I mean, it looks like you can't make a judgment based on just an x-ray, but you can see how we would call that osteopenia. You can see how osteopenic that is on a plain x-ray. That vertebra, you can see, is not square. It's been compressed at the top, so that's a compression fracture, and there's probably a compression fracture above that. So that would be osteoporosis of the thoracic spine. If you would, and those would be fractures, if you would do an MRI of the spine, this patient's turned the other direction, but here is the spine, and that is a fracture, and that is a fracture. The fracture would light up as brilliant. Now with age, within the thoracic spine, you're upright during your middle years, but if you get osteoporosis of the thoracic spine and get compression fractures, then you gradually become more humped back and you lose your posture, and that affects not only the spine, but it also affects the abdomen because as your thorax sort of drops, it almost here connects with the pelvis, and so the abdomen is more protuberant and the ribs are pretty much lying on the rim of the pelvis. Now, the bone is a wonderful organ. It is constantly building and rebuilding, and not all organs do that. If you break your bone and you break it in half and you put the two ends together in a cast, they grow back together, and you have cells in the bone that are constantly building bone, and you have cells in the bone that are constantly breaking down bone. And it's this balance of those cells that becomes abnormal and becomes the clinical manifestations of osteoporosis. Basically, with osteoporosis, the breakdown team beats the build-up team. So an osteoporosis bone under the electron microscope is going to look like this, whereas a regular bone is going to look like that, because this has had its bone resorbed. Okay, so if you looked at it in the microscope, that's osteoporosis, and that's regular bone. So you've lost bone mass. So how common is osteoporosis? Vary. It's a major public health problem. Probably 44 million Americans, or 55% of people over age 50 years old. Probably 10 million individuals are estimated to already have the disease, and 34 million may have osteopenia or low bone mass, placing them at risk for osteoporosis and fractures in the future. Let's talk a little bit about fractures. 1 in 2 women over the age of 50 will have an osteoporosis fracture in their lifetime. Fractures due to osteoporosis are most likely in the hip, spine, and wrist, and the number of fractures due to osteoporosis is expected to rise multifold by 2025. The risk factors for developing osteoporosis are multiple. Female, particularly Caucasian or Asian, older age, family history, and I'd emphasize that family history is probably a major risk factor. We don't understand the genetics yet of osteoporosis, but why do some people get soft bones at an early age and others don't? It's probably genetic, and if we look down the road, we're talking about, if you talk about public health or personal cures for this, it's probably going to be on the gene side, understanding the genetic breakdown of this. A prior history of fracture is a risk factor. Low estrogen, which is what happens with menopause. Other younger women that have low estrogen states for one reason or another are high risk for osteoporosis. Low calcium intake, inactive lifestyle, smoking, alcohol in excess, certain medications, particularly steroid drugs, and steroids are necessary drugs for certain illnesses, but they have the side effect of rapidly progressive osteoporosis. And certain illnesses where your calcium and vitamin D metabolism are abnormal have osteoporosis as part of the illness, such as anorexia, such as rheumatoid arthritis, such as colitis, sprue, celiac disease, etc. Prevention: about 80 or 90% of your bone mass you acquire when you're young. There are steps that younger folks can take to try to help with osteoporosis. It's adequate calcium, vitamin D, regular weight bearing and muscle strengthening exercises, curtailing cigarettes. And I would say of the folks in which we read bone densities, probably some of the worst bone densities are those with chronic cigarettes, I would say. Heavy alcohol, etc. Now let's talk about calcium and vitamin D. But according to the National Osteoporosis Foundation, then underage women need 1,000 milligrams of calcium in their diet a day, and over age 50 need 1,200 milligrams of calcium a day. Their recommendations for vitamin D, under age 50 are 400 to 800, over age 50, 800 to 1,000. Here are some foods that have some representative calcium intake, or calcium in them. So other things as far as prevention are weight-bearing exercises. Walking is probably the number one. You know, if you build strong, you build your back if you can walk. Now, a lot of people have bad knees and other reasons they can't walk. And then resistance, mild resistance training exercises strengthen muscles around bones and joints, and they put pressure. Anytime you put pressure on bone, it strengthens it. And avoiding alcohol, cigarettes, and sedentary lifestyle. Osteoporosis is not curable, it's treatable. Many steps you can take to manage the disease and reduce your chance of fracture. The reason to evaluate somebody for osteoporosis is try to reduce their chance of fracture. Just like the reason to check a cholesterol is not to lower the cholesterol, but reduce your chance of a vascular event like a heart attack or a stroke. So this is all sort of preventative. And the types of things that are done to evaluate somebody for osteoporosis are history. You know, we want to know if do they have any of those bowel diseases, do they have any calcium metabolic diseases, etc., that predispose them to osteoporosis or trouble with treatment. An examination, a bone density test, a FRAX, and certain laboratory tests. Well, a bone density test is really the only diagnostic test that can diagnose osteoporosis before a fracture occurs, and it gives you an estimate of what your chance of fracture might be. Who should have a bone density test? This has also had a little controversy in the last year. The National Osteoporosis Foundation recommends if you're 65 or older, and or a man at 70, if you've broken a bone. If you've broken a bone after 50, particularly if it was not high trauma, then that raises the question of whether you have osteoporosis and you don't know it. If you're a woman of menopausal age and you have risk factors, this is the data. These are the data that you might get on a bone density before it's read, and it may look something like this. These are actual bone density of the hip, and we measure the total hip as well as the femoral neck. That's going to be a summary of the T-scores and Z-scores, and that's going to be it mapped out. So this right here reads, this patient has a 0.2% risk of a hip fracture in the next 10 years. Okay, that's great. We've already seen that the bone density is great. This patient has a 6% chance of having any kind of fracture in the next 10 years. And this FRAX, 65, same information, except the patient's had a prior fracture, not unexpectedly, because they have osteoporosis. And the risk of a hip fracture is 6.4%. A 10-year risk of hip fracture is 6% a year, or 6%, and the major chance of any kind of fracture is 24. Okay. Now, not everybody breaks a bone. There are other issues besides the bone density that have to do with fractures. The consensus of treatment from the National Osteoporosis Foundation and the WHO, the World Health Organization, is patients should be treated if they've had a vertebral fracture, if they've had a hip fracture. And why? Because once you've had one, your chance of having another is very high. If your bone density is equal to or worse than minus 2.5 in any site, that means you have a diagnosis of osteoporosis. Or if your FRAX, which is your estimated risk of fracture, is greater than 3% in the hip and greater than 20% for any fracture. Now to the fun stuff. There are several classifications of drugs for osteoporosis, and the first I'll talk about are what we call the bisphosphonates. The bisphosphonates are basically detergents. They are phosphorus products. They're very long-acting, and that consists of Fosamax, Actonel, Beniva, IV Beniva, and IV Reclass. The two IV drugs were developed because this class of drugs, when taken orally, has a lot of stomach trouble. A lot of people can't take it if they have esophageal disease. And as a rule, the bisphosphonates as a class decrease your risk of fracture by 50%. There are problems with the bisphosphonates. The hot thing over the last year is how long they should be given. Most practitioners have moved toward giving people drug holidays from the bisphosphonates if they've been on from 3 to 5 years. Calcitonin is an old drug by injection. In the old days, if people had vertebral fractures, hip fractures, we used to put them on injectable calcitonin. That's a hormone that's natural that does help build bone, does help regulate calcium metabolism. The problem is it's not a very good drug. It's available by nasal spray. It just doesn't have very good fracture data. And if you have a high risk of fracture, you know, it's sort of like cancer. You don't want to take, well, this drug doesn't really have much side effect. Maybe you could take that. It might help you some. Or do you want to take the drug that's really going to take care of it? And so we try to use the drugs that really take care of it. And estrogens, particularly in perimenopausal women, back in the old days, that's all we had was estrogens, and they're still used in people. Some people make the choice to stay on estrogens long term for bone health, even though they have cardiovascular risks, which came out in the last few years. And then to try to mimic the response that one gets with estrogen, then you had what we call the SERMs, a selective estrogen receptor modulator, and that's Vista. And that drug has been manipulated such that it has the pros of estrogen, which are improved bone health, but it doesn't have the cons, which would be uterine cancer or vascular disease. It does have some hot flashes, and it does have swelling like estrogen sometimes do. And so, but it's a daily pill, and it doesn't upset the stomach, and it's not a bisphosphonate, and sometimes that's a choice. It's not our best drug, but it is a drug. And then we have Forteo. Forteo is a shot. It's a parathyroid-like drug, and it's a daily shot, which is a problem because some people don't like that. It comes in a clicker. It's very easy to use, but it is a clicker, like some of the new insulins are. And it's probably our best drug. I tell folks that's our Cadillac drug. If you have a bad osteoporosis and you failed the bisphosphonates, or if you fractured through it, then Forteo is our best drug. But it is daily injection. A lot of people don't like it. They're looking at trying to take the drug and through technology implanting something in you that has a little chip or something that'll release a little bit out of it every day. So all you have to do is get a little pack, get a little insert, and you won't have to give yourself a shot. But that's probably on down the road a little bit. And then the last one to come to market is an antibody. Now in rheumatoid arthritis, we use a lot of antibodies for inflammation. This is an antibody to one of the proteins that's useful in building bone. It's called Prolia. It's a twice-a-year sub-Q injection.
I frequently come to a lot of the seminars. I pick and choose what I need to know or what I'm interested in. I really enjoyed today because I'm 73 and I needed the information about what affects people in my age as far as osteoporosis and how to take care of myself.
The seminar benefited me greatly. I am a patient of Dr. Knodl's because I have osteoporosis. So much of the information I was aware of, but there's always new information, and the latest information I need to keep abreast of. I enjoyed the seminar very much and will come to others.